So good morning. It's a true pleasure to welcome you to this important gathering, united by a shared goal that lies the heart of our collective mission, that is improving therapeutic adherence to reduce the global burden of cardiovascular diseases. 2025 is much more than just another year. It is a year of action for cardiometabolic health. Following the launch of the European Cardiovascular Health Plan, as Jackie was mentioning, and the first ever World Adherence Day, we are witnessing a decisive shift toward a new era of implementation and accountability in cardiovascular care. Therapeutic adherence is often overlooked, yet it is fundamental to achieving the outcomes we strive for in prevention, treatment, and lifelong disease management. Poor adherence is silent, yet potent threat, accounting for countless preventable heart attacks, strokes, and deaths each year. The burden is particularly heavy in the low and middle income countries, where systemic barriers to adherence only deepens existing health inequities. And that is why I'm especially proud of the momentum we are building together. The inaugural World Adherence Day, launched on 27th March 2025, marked a turning point. What began as an urgent call to action has grown into a truly global movement. 14 major organizations, including the World Heart Federation, European Society of Cardiology, International Pharmaceutical Federation, International Council of Nurses, International Atherosclerosis Society, International Diabetes Federation, International Society of Hypertension, and European Society of Hypertension, among others, joined forces to lead the charge. The campaign's success was resounding, with over 70 million impressions on social media, estimated 500 million lives touched. It sent a clear and unified message that is, therapeutic adherence matters, and the global community is ready to act. From the inception, when we met at the European Society of Cardiology 2024 in London, to its widespread adoption and visibility, World Adherence Day has already become a powerful symbol of shared purpose and resolve. As we convene today, let us look beyond isolated efforts and commit to systemic, sustainable solutions that place people with lived experience at the center. Let us continue to build bridges across disciplines, sectors, and regions to ensure cardiovascular health for everyone. Finally, I would like to extend my sincere gratitude to Servier for their leadership, vision, and partnership in supporting the creation of World Adherence Day as a member of our task force and for making today's event possible. So thank you very much, and let's start with the...
Thank you. Thanks very much indeed, Jagat, for that opening remarks. Just to recap, obviously, we want to raise awareness of the importance of adherence. You in this room, I think, know about it. But I think also we want to identify some real actionable strategies to improve adherence at individual level, at systemic level, policy level. And that's why we've got some great panelists and speakers to talk about how this can happen. And we want to strengthen collaboration. And again, it's great that, that you're all here. Without further ado, I want to talk about the national perspective, and this time from Kenya. Sadly, Dr. Uma Aluga, the Principal Secretary, cannot attend, but we're absolutely delighted that Elizabeth Onyongo, who is the Head of NCD Prevention and Control Unit at the Ministry of Health in Kenya, a public health specialist, is joining us, and she is going to talk yeah, please come forward. Lovely. She's going to give us a presentation, a keynote presentation. So thank you very much indeed.
Apologies from our Principal Secretary, Dr. Uma Oluga. He's a physician, like most of us here. but he's involved in another parallel event at the World Health Assembly. So allow me to read his speech. So good morning, esteemed colleagues and friends. It's a great honor to speak with you today at this important side event of the 78th World Health Assembly. I extend my sincere thanks to the World Health Federation and all partners who brought us together to focus on a theme so central to our shared mission. Better adherence, better control, better health. This conversation could not be more timely. As we move toward achieving universal health coverage and the Sustainable Development Goals, the need to improve adherence and control in cardiometabolic diseases is both urgent and essential. We know that cardiometabolic diseases, especially CVDs and diabetes, are among the leading causes of death and disability globally. CVDs alone claim nearly 20 million lives each year. Diabetes is rising at an alarming rate, and its consequences are devastating, particularly in low and middle income countries. In Kenya, NCDs account for 41% of all deaths. A third of our population lives with hypertension, yet only 22% are on treatment, and just 3% have their blood pressure under control. We also know that about 5% of Kenyans have elevated blood sugar, but 87% have never had their levels checked. And only 40% of those diagnosed are receiving care. So what is at the core of this challenge? One, it's access and adherence. So despite having effective treatments available, far too many patients struggle to access and stay on them. Globally, nearly half of those living with chronic conditions don't follow their treatment plans, leading to preventable complications, premature deaths, and increased healthcare costs. Improving adherence is not just about asking patients to comply, it's about building systems that support people. It means ensuring education, accessibility, affordability, trust, and most of all, it requires a people-centered approach. So at the Ministry of Health in Kenya, we have taken deliberate steps to place therapeutic adherence at the heart of our national response to NCDs. Under governance and policy, we have established a National Interagency Committee on NCDs and a CMD, Technical Working Group, to promote inclusive and multi-sector collaboration. So me as Elizabeth, I'm actually the chair of this CMD, TWG. It's a recently established group. So we are yet to really have meaningful meetings. Under financial protection, through the Social Health Insurance Act, we introduced 3 important funds covering primary care, emergency and chronic illness, and the overall health insurance, just to ensure that there's equitable access and protect our citizens from catastrophic health costs. And awareness and screening, we have the national campaigns like the World Hypertension Day, which on 17th we marked it in our country, and the World Diabetes Days. So these have allowed us to screen thousands and raise awareness on prevention and disease control. At the heart of our approach is primary health care. We are investing heavily in community health promoters. So as we know, we already have 107,000 community health promoters, and each of them is assigned around 100 households, assuming that each household has around five members. So these community health promoters, we train them to screen for blood pressure, blood sugar, take heightened ways to get the BMI, to educate communities, to monitor adherence, and to ensure timely referrals. In addition to that, these community health promoters have been issued with smartphones so that they're able to capture real-time data and transmit it. So we've revised their training curriculum and introduced standardized tools to enhance quality of care. We've also updated our national guidelines, essential medicine list, and protocols for NCD care at the primary level to make care delivery more streamlined and effective. So one of our most impactful changes has been the inclusion of fixed dose combinations for hypertension. And this one we've included in the essential medical list. This makes it easier for patients to stick to their treatment plans and improves outcomes significantly. So again, in addition, we have lowered the use of some of these medicines to primary care levels, because previously you could find that essential medicine that could be prescribed at lower level was not included for that. So now you can have treatment being initiated at the primary care levels. So we are also working to bring care closer to the people in underserved areas. Long distance to health facilities continue to be a major barrier. So our goal in Kenya is to ensure that no Kenyan lives more than 5 kilometers from a health facility. So to achieve this, we're integrating NCD services into platforms like HIV care, which already have strong community penetration. So with support from partners such as the World Diabetes Foundation, we are screening over 500,000 individuals for hypertension and diabetes through an integration project. And with support from the Global Fund, we are rolling out the WHO PEN package in HIV clinics across 12 counties, ensuring that people living with HIV are also screened and treated for NCDs. So we are also proud of our partnership for the education of health professionals. This is a project that's supported by Novo Nordisk Foundation. This is an initiative in building capacity of students at the middle level colleges in both government and public training colleges on cardiometabolic disease. So we want to train not necessarily for now, but also for the future. Professional associations like the Kenya Cardiac Society and the Kenya Diabetes Study Group have been invaluable in supporting CMD management. And patient support groups continue to play a critical role in improving adherence at the community level. So we're engaging people with lived experience just to support others. We have the peer educators also coming to support in adherence. So in addition, we are integrating CMD care with other disease programs, including maternal and reproductive health, and have developed the self-care guidelines for conditions like diabetes and hypertension, empowering patients to take control of their own health. So this guideline, developed by the Division of Reproductive Health, but we as NCDs, we were invited to include our content there. But we know Kenya cannot do all this alone. So this is a global challenge. Closing the adherence gap must be a shared priority for governments, civil society, academia, private sector, most importantly, patients themselves. So we must invest in patient education, address systemic and financial barriers, leverage tools to track adherence, and embed adherence metrics into national health strategies. And above all, we must listen. Why do people stop treatment? What are the barriers? How can we help them stay on track? Because adherence is personal, and so must be our solution. In conclusion, let us move adherence from the margins of policy to the center of health strategy. Without adherence, medicines lose their power. With it, we unlock the full potential of our health systems. So Kenya is committed. We're embedding adherence into our policies, strengthening our systems and collaborating with other partners to scale what works. Let us work together so that every prescription counts and every individual living with cardiometabolic condition can live a longer, healthier life. So for better adherence, for better control, for better health. Thank you.
Thanks very much indeed, Elizabeth, for that really comprehensive talk on what Kenya is doing. Some really excellent initiatives there and embedding policy into policy, as you say. And I love the peer support element too. That's fantastic to encourage adherence. So we've heard from the Africa perspective from Kenya. We now have a recording, a video presentation from the European perspective. We're going to be hearing from Ms. Romana Jerkovic, member of the European Parliament, member of Parliament for Croatia. She's vice chair on the Committee on Public Health, and she's been instrumental in implementing this European cardiovascular health plan that Jigat talked about earlier. So now if we could play the video, that would be fantastic. Thank you.
Ladies and gentlemen, although I was not able to join you in person at this World Health Assembly side event, I am happy to address you on the topic of therapeutic... Ladies and gentlemen, although I was not able to join you in person at this World Health Assembly side event, I am happy to address you on the topic of therapeutic adherence, an issue that deserves far more political attention than it currently receives. In the European Union, cardiometabolic diseases, including cardiovascular disease, hypertension and diabetes, remain the leading cause of death and disability. Yet, despite the availability of effective treatments, it is estimated that up to 50% of patients discontinue their prescribed therapy within a year. This is not just a medical failure, it is a policy failure, and it is patients who pay the price, with worse outcomes, avoidable hospitalizations, and ultimately shorter lives. That is why I welcome the recognition of adherence as a strategic priority in the context of the World Health Assembly. I warmly support the establishment of World Adherence Day, which makes an important step in elevating this issue on the global health agenda. But awareness must now lead to action. In the EU, we are working to make that happen. The recently announced European Cardiovascular Health Plan represents a critical opportunity to tackle adherence as a central pillar of our strategy to reduce the burden of chronic disease. But policy plans alone are not enough. If we want better adherence, we must first invest in health literacy. Patients cannot follow treatment instructions they do not understand. They cannot manage conditions they have never been educated about. Health literacy is not just a personal skill, it is a social responsibility, and building it requires time, resources, and above all, people. We need proper funding for large-scale awareness campaigns, integration of health education into curricula, training of healthcare workers and community outreach initiatives. And yet, we are seeing worrying signs in the opposite direction. The EU for Health program, established in response to COVID-19 pandemic, is already facing budget cuts. And as we look toward the next multi-annual financial framework, there are real concerns that public health will once again be deprioritized. This is deeply concerning. We cannot promote adherence without investing in prevention, education, and access. It is also time we adopt smart and proven solutions. Single pill combinations, now included in the WHO model list of essential medicines, have been shown to improve adherence dramatically by reducing pill burden and simplifying drug regimes. They must be available across Europe and integrated into treatment guidelines and reimbursement policies. At the same time, we must unlock the potential of digital health tools. From reminders and apps to telemonitoring and e-prescriptions, technology must be inclusive and patient-centered. Digital health is not a silver bullet, but it can be part of the solution if implemented right. We also need to value and support the health professionals, pharmacists, nurses, general practitioners who serve as the bridge between prescription and adherence. They play a key role in counseling, follow-up, and building trust with patients, and should therefore be better resourced. And let us not forget that adherence has a gender dimension. Women often present different symptoms for cardiovascular disease and are more likely to be misdiagnosed or undertreated. They also report higher rates of side effects from certain medications, which directly affects adherence. If we ignore these differences, we fail half of our population. It is a matter of social justice to build a system that recognizes these differences and respond to them with tailored care, inclusive research, and real policy change. Let me be clear, adherence is a political choice. It is a choice to invest in what keeps people healthy, not just what treats them when they are sick. It is a choice to fund prevention and the daily work that makes longer lives possible. So today, I join your call to action. Let us make adherence a formal, founded priority in every EU and national cardiovascular and chronic disease plan. Let us protect health budgets from cuts that would undermine decades of progress. And let us place patients, professionals, and people at the core of everything we do. Ladies and gentlemen, better adherence means better disease control.
See a very impassioned call there from Romana. Thanks to her for recording that. So a slightly different note now. I'm delighted to welcome from Portugal, we have Professor Ana Abreu. Ana is Professor of Cardiology at Lisbon Medical School and also President of the European Association of Preventive Cardiology. She'll be speaking for 10 minutes on the role of adherence in tackling cardiometabolic diseases. What are the challenges? What are the opportunities? Thank you, Ana.
I don't know if this is...
Yes, it's working.
Okay. Thank you so much. It's a pleasure to be here. Thank you to World Heart Federation. I'm here on behalf of WHA. I actually work in preventive medicine and public health, being a cardiologist. I direct this department on the University of Lisbon, and also I coordinate a team, a multidisciplinary team on cardiac rehabilitation. So this is a very, very dear topic to me, talking about the challenges and opportunities of cardiometabolic disease. Yeah, sorry. So we have an evolving landscape of cardiometabolic diseases, which is really epidemic. We know that the numbers are increasing. A group of disorders which are interconnected, like type 2 diabetes, dyslipidemia, hypertension, obesity, they are linked to complications like ischemic heart disease and heart failure, and they are recognized now as the leading cause of death globally with big numbers. We know that we had significant advancements in diagnosis, in treatment, but however, we continue to have big numbers and an increasing prevalence of these diseases, these cardiometabolic diseases. Something is happening. So we have a lot of challenges, but the big challenge is to manage well chronic cardiometabolic diseases, which are many times asymptomatic and chronic. Many times there is the difficulty of diagnosis. There is the lack of treatment, initiation, and intensification of treatment, and there is poor adherence to treatment, to therapies. This doesn't work, sorry. So what we think is the impact of poor adherence leads to suboptimal control of these diseases. We have more severe cases of hypertension, diabetes, dyslipidemia, cardiovascular events. We have more preventable complications of cardiovascular disease, more mortality, and we have also more risk of hospitalization, and we increase all-cause healthcare costs, which is a reality, a very important topic today. In this process of adherence, we have mainly 4 steps. We know adherence is the extent to which a person's behavior corresponds to which is recommended from a healthcare provider, and this includes first, the informed consents, since adherence is something active, something shared, not compliance, not passive. Second, initiation of treatment with the first dose of medication correctly prescribed or lifestyle change. Third, implementation of dosage regimen until the end. And finally, the 4th step is interruption in the end of the treatment plan when we want to interrupt, which many times is not possible in chronic cardiometabolic diseases, despite many of these being asymptomatic. So what we know is that many patients with chronic cardiometabolic diseases do not adhere to treatment. As you see, for hypertension, in 2 patients, 1 do not adhere. We have 50% of non-adherence. Dyslipidemia, 73%. 38% for diabetes. Coronary artery disease is not so bad, 21%, but heart failure, you can see 90%, so it's really, really big. Why are patients not adhere to treatment? You have a whole list of motives, of factors, which of course I'm not going to read. And we also have to think about psychological determinants of non-adherence. Just imagine the quantity of people who have cognitive disturbances, loss of memory. This is a main issue for adherence, as many others as you see. We don't have only challenges, we have a lot of opportunities, some very good opportunities. This was a document produced by ESC in 2023, how to optimize the adherence to a guideline-directed medical therapy in secondary prevention of cardiovascular diseases. And this is extensive to cardiometabolic diseases. And one of the take-home messages, one of the statements was that we always need to work in 5 dimensions to increase adherence. We don't only work with the patient. We need, as you heard before, health politicians, all other healthcare professionals, patients, the environment, the disease, the therapy, everything needs to be well seen. So in this document, you have several actions to optimize therapy adherence in these diseases regarding the disease, the patient, the therapy, the healthcare provider, and the healthcare system. But it's not only looking at that, at the 5 dimensions. We need also to look at predictors of therapy adherence in specific cardiovascular disease and conditions, meaning that if you are looking at obesity or hypertension or dyslipidemia or diabetes and so on, you have different factors. You can have different factors of non-adherence. Age may be different factor, early age or old age in different diseases, and also gender, and also anxiety. So you have different factors of non-adherence regarding different situations. These guidelines from 2024 from ESC regarding management of chronic syndromes, coronary syndromes, have said that recommendation 1A is the use of mobile health intervention. Text messages, apps, wearable devices, they are recommended to improve patient adherence to healthy lifestyles and medical therapy. And recommendation 1B is the simplification of medication regimens, like using fixed-dose drug regimens. This is also recommended. And if you look to the image, this summarizes very well ways of supporting adherence. You can see that we should include multidisciplinary behavioral interventions, including cognitive behavioral techniques. So it really needs to be multidisciplinary. The use of fixed-dose combination pills and simplified medication regimens, mHealth and telehealth, and good communication, structured tool, and visual images, which are quite important in communicating. So also, we should address prompts and feedback evaluation. You know this document, a call for action for non-adherence in long-term therapies, more than 20 years ago from WHO, which was quite important. From there until now, several actions have been taken. We have this document from CARDAS, which evaluates the reflection on these 2 decades regarding adherence, and who evaluates with several experts the top-ranked targets for medication adherence management for the next 20 years. And I would like to highlight, for instance, the implementation of comprehensive measures of medication adherence, establishing a stronger connection between adherence metrics and health outcomes, and also the need of incorporation of medication adherence as a standard measure in routine clinical practice. So a lot of gaps in knowledge exist. One of the big gaps we need to evaluate in research is which interventions have the broadest impact on maximizing adherence to therapy across patient groups or health conditions. It's not equal for all. So I know there is a big list of actions, a big list of strategies, but I would like to summarize a little and to put 10 strategies to improve treatment adherence. So first will be to have tools to remind. We have to have written tools. It can be online tools. Then we need to have a personalized treatment plan, understanding first each patient's medication taking behaviors. We need effective communication, not only talking about effective the effectiveness of drugs, but also talking about side effects. Then we should have the constant support of the patients and direct collaboration, something really interactive. We have to have shared decision with the patients, considering the financial burden to the patient, because this is one of the reasons many times they stop medication. So we need to assess health literacy, and after this, do education, empower the patient, increase self-efficacy to reduce the complexity with fixed dose medications, with polypill. We should have long-term coaching with follow-up of these patients, engage the community with multidisciplinary teams, use technology, as you heard before, with the apps, digital tools, artificial intelligence, which can help a lot identifying non-adherence parameters, and of course, do not forget systematic evaluation of risk for non-adherence. This is very important. So finally, to conclude my presentation, I would like to show you some pictures from my cardiovascular rehabilitation program, which has been accredited by the European Society of Cardiology, because you need to do something that you know you are doing well. You need to know that it will have good effects with safety for the patients. And the truth is that cardiac rehabilitation is one of the strategies that really increase adherence to secondary prevention. So, to conclude, this sentence from Haynes, which was in the document of WHO, is really important even nowadays. Increasing the effectiveness of adherence interventions may have a far greater impact on the health of population than any improvement in specific medical treatments. Why? Because the best pill will produce no effect if not taken. So thank you very much, my patients and my team.
Thanks very much indeed, Professor Albro. That's a fantastic presentation, and again, another amazing call to action. So we're coming now on to our panel discussion, and we've got a great panel for you to discuss these important issues and to think about some of these solutions that we've been discussing earlier on. So let me first of all, I don't get in the way here, but I want to introduce to you Dr. Kumivi Agboy-Igbar, who is a public health physician from Togo originally, but now based here in Geneva at the World Health Organization, a medical officer for cardiovascular disease. So welcome to you, if you want to take a seat. We also have Dr. Michelle Winoka, Executive Director at the International Atherosclerosis Society. Welcome to you. We have Dr. Virginia Olmos, Vice President of the International Pharmaceutical Federation, who is joining us from Uruguay. So fantastic to be here. We have Dr. Jackie Marlouf, who is the Vice President of the International Diabetes Federation, again, comes from Lebanon, so that's a great perspective to have. As you wish, yes, as you wish. And we also have Hoishan Fodelaida, who's from the International Council of Nurses, a Senior Policy Officer, so welcome to you, so please sit down. We are still awaiting one of our panellists, so forgive us. Our patient from Zambia, patient advocate, will be joining us soon. So actually I think now I might just sit here as we've got a bit more space. Okay, so let me start with you, Gomivi. Oh, tissue, yeah, in the way. We've got a lot to cover, and I'm so sadly I'm only giving you 5 minutes each. Obviously, as Professor Abrose mentioned, the WHO first identified this issue of adherence, lack of adherence in 2003 report. And I wondered if from your perspective, if you could talk about how the landscape has changed since that publication. Obviously, Professor Abrose talked about some of the gaps. What do you see as the gaps that still need to be tackled?
Thank you very much. Good morning, everyone. Very delighted to be invited to this panel on behalf of WHO. Yes, 20 years passed now since the launch of the report on, medication adherence by WHO. Since the release of the report, I think that we can talk about various impacts, especially at policy level, because the report brought more attention to this special issue. And in many of our low and middle income countries, we've seen the increase of number of countries that have started developing specific strategies for NCDs, prevention and control. And adherence to medication is one of the key pillars, when it comes to non-communicable diseases. I'm very happy about the presentation by Prof because it mentioned the importance of access when it comes to adherence. We are still facing a lot of challenges when it comes to this specific topic in low and middle income countries. Yes, we are supporting countries to train healthcare workers, to educate patients, but different challenges, especially financial bottlenecks, out of pocket payments still delay access to treatment. And sometimes, as Prof has said, people wanted to take their treatment, but they don't have the capacity to pay for it. So those are some of the key challenges that we can mention. How do we fix them? We need to make sure that we are able to decentralize care. So if I'm living in rural and remote area, if I have to travel like 100 kilometers to get access to care, then it's difficult for me. Maybe I will miss up my, my appointment. So it's difficult. Yes, if I went to a facility, my level of education is very low in a country. I'm not speaking your French or your English as a main language. So how do I get the knowledge from the disease, also from the condition, so that I can adhere totally to the treatment? So those are some of the key challenges that we can mention when it comes to adherence to care. Yeah.
Thank you for that. And also we've heard from Kenya that they are introducing, or they have introduced, community health promoters to get, to help the people you're talking about to learn about adherence and why it's so important. But I wondered if you could just tell us a few more steps that you think member states could take to encourage adherence.
Thank you very much. So first thing, I think it's a policy level action. So we need to make sure that medication for cardiometabolic conditions should be part of national health benefit package. So we have the accessibility. Then when we have the accessibility, we need to move to universal health coverage by implementing tax sharing, tax shifting, training community healthcare workers, nurses, general professionals to provide the services. And then train the healthcare workers to deliver the real message using imaging, using local languages to teach people how to take their medications. And following those straightforward steps, will lead us to have, that adherence that we're looking for.
Okay, and of course, Professor Bro mentioned single pill combination for cardiovascular disease. It's in the model list of essential medicines from 2023. How can these pills contribute to adopting adherence, and what policy levers, maybe more importantly, can be used to actually get them adopted?
Thank you very much. So I think, especially in Africa's context, we learned a lot from HIV treatment. HIV, the first treatment started in year 2008, and it started with a lot of medications. But we see that the use of single pill medication has, increased adherence to treatment. And that's something that WHO wanted to emphasize on for cardiometabolic diseases. You see that simple pill regimen is now part of national essential medicine adopted by WHO. And we are encouraging countries to use what we call simple based protocol. For example, hypertension treatment. You have simple standardized protocol to the heart package that even a nurse can use to initiate treatment for either diabetes, either hypertension. So this will help, people to have access to the care maybe just once a day and increase adherence to medication.
Okay, thanks for that. I'm going to leave it there. I want to move on now to a different speaker because we've got lots to cover. I want to come on to Dr. Winoka. From your perspective, what are the key challenges? Anna has mentioned, overall in terms of cardiometabolic diseases, but with atherosclerotic cardiovascular disease, how does non-adherence actually impact, if these lipid-lowering therapies are not being taken?
That's a fantastic question. Thank you for it. And I think one of our biggest challenges when we're thinking specifically about lipid lowering therapies is that often there's not a symptomatic benefit, right? So people, if you have high cholesterol, you may not realize it, you may not feel it, right? So it's really hard sometimes to convince a patient to take something to fix something they didn't know was a problem, right? Or they don't perceive to have a risk for. It's not like some other conditions, perhaps a headache, for example, where you have throbbing pain or hard to see, right? You take some medication and you feel better. We kind of have that invisible risk sometimes when we think about high cholesterol.
So how do you get over that then?
That's a challenge. I think if there was a silver bullet answer, I think
Yeah.
our conversation today would be really, really different, right? So I think there's a couple of things that we can do and that we're working toward. I think obviously the single pill combination has been mentioned as one that is valuable, but I think so much of it is meeting patients where they are, recognizing that different patients have different challenges. Sometimes it could be a transportation issue. Sometimes it's a timing issue, right? Thinking about going back to the clinic to pick up your medications, particularly if you're in a public setting, you have to go between certain work hours. Well, that's difficult in terms of transportation and public access. So we've seen some different programs in place to help relieve that. I was speaking with our president, Dirk Bloom, who's in South Africa, and he said they have found the kind of pill locker programs to be particularly effective. So the patient's medication goes in a locked storage, and then they get an SMS text message code that they can go at their convenience to pick it up. So it kind of takes the timing of that challenge out a little bit, but that's just one example. Still, obviously, you mentioned as well the cost. Even statins, for example, have been generic for a long time, and sometimes even the low price of those is unaffordable. So still many challenges to face.
I loved Anna Abro's circle where it had on the end of it was the digital solutions, but the one next to it, the very first one, was pen and paper writing it down. And I think we've got to think about both of those elements because they're going to be. I still write everything down as a journalist. Okay, but I want to come on just briefly. We heard about patient education, patient communication. We heard about peer support workers. What in your opinion, what can help in getting across? You've mentioned some of the digital solutions for another aspect, but about patient education and communication, what's other things that might help?
Absolutely. I think that I want to give credit to a lot of the patient organizations that do great work in peer advocacy and peer training. I think it's one thing to say that it's from your physician, but we really are facing a huge crisis of misinformation, particularly in lipid-lowering therapies. It's almost a constant conversation, particularly with our members and our partners across the Middle East, that the misinformation, Dr. TikTok, someone who perhaps is minimally medically trained or not medically trained at all, and they're maybe the conversation starts out convincing, right? Or they say some good things and write some facts at first, and then it kind of veers away. And then we find that, we're coming in and we're trying to convince a patient to take a medication that, again, they may not see a symptomatic benefit for. And they're kind of saying, well, this person on television or on my phone or on social media. And so really kind of fighting that fake news and that misinformation, I think, is an ongoing battle, and one that we really need to, as a community, I think, step into, really helping people understand the benefits of lipid lowering therapies.
Well, that really helps me on to our next speaker, Dr. Virginia Olmos, because pharmacists are obviously trusted health professionals who can potentially counter some of those messages that you've just been talking about. So I want to ask you, Virginia, how can pharmacists be more effectively engaged to support patient adherence, in these chronic conditions? And I wonder if you could talk about some of the successful initiatives that have been led by pharmacists that might be scaled up and adopted by others.
Okay, good morning. Thank you for the invitation. Apologize for my English because I am a native Spanish speaker. And pharmacists are the most accessible healthcare professionals in many communities because we are in the pharmacy, the community pharmacy, and we have the unique position to support the adherence. Particularly in the people with chronic diseases. Our regular contact with the patient and our expertise in the medicine use make key are a contributor in individual and public health strategies, and crucially in the adherence support, not only addressing the barriers, it's important to our contact with the patient and change the behavior change process. That requires patient education, motivation, interviewing, and follow-up. All the tools that the pharmacist can deliver through the people-centered care. As pharmacists work with the patient to identify the causes of non-adherence, and you must engage the patients to promote adherence, and for that we need to follow up the treatment, and we understand the concern of the patients too. For example, their belief, their expectations, and their motivations too.
Can I ask you a question there, Virginia?
Yeah.
Are we talking about, how often is it that patients will come into a pharmacist to ask questions about how to take their pills, how to continue taking their pills? Or is this more proactive policies by you to tell them to come in and review medicines?
Yes, we have some successful pharmacist-led intervention. For example, in low and middle income countries, involved with the treatment and the antiretroviral treatment follow-up, or the diabetes education, or glycemic monitoring in the community pharmacy. And for example, in another country for Latin America, as Brazil, in the community pharmacy, they improve the access to the medication, subsidizing some medications, and with support adherence and pharmaceutical care. And in some opportunities, we can recommend to change a fixed doses combination medications in order to reduce the pill burden, and it was the better adherence and to the treatment in the cardiological diseases.
Sure.
And the FIP support this kind of activities through a lot of publications that we have in non-communicable diseases, and support the pharmacists and our work to detect non-adherence.
Sure.
and support with this kind of tools.
But of course, like many other healthcare professionals, certainly where I am in the UK, pharmacists are very, very busy. And I'm presuming it's hard to give the kind of care that you talk about, especially if there's non-payment for it. So I wondered, what are the what are you calling for in terms of regulatory reform to enable pharmacists to play this more proactive role
Yes,
globally?
of course, yes. Yes, in order that the pharmacies to fully unlock the potential that the pharmacies can do in the pharmacy, the policies and the regulations reform are indeed essential. We need to allow to operate in the top of our scope, and for that first we need, for example, to recognize the pharmacists as part of the multidisciplinary team, and with the reimbursement accordingly with our activities. And secondly, we need to recognize as part of the routine care, and we need to have access to the medical records and the digital tools in order that to support the treatment, and we have a communicate with the patients and the other healthcare professionals too. And we advocate for education and training and the competence we need for this kind of services. And FIP have a policy statement in the role of the pharmacist in non-communicable disease, and we support this change, and if we can strengthen the role of the pharmacy, we have a better adherence, a better control of the disease, and a better health for all too.
Okay. Thank you very much indeed, Virginia, for those comments. Let me move on. I'm going to come to this side of the room now. Jackie Marloff, diabetes, right? We've heard about changes in the health system for, generally, and also the role of pharmacists. But what do you think? What changes in the health system are needed to have support this day-to-day? Diabetes management. It's obviously a condition which needs a lot of care and treatment. And what about this communication between healthcare providers and people with lived experience? How can that be improved, be more consistent? We will be hearing from our patient, we hope. But yeah, what's your view?
First of all, good morning, everyone. Thank you for having me here. Of course, I have the honor and the pleasure of representing the International Diabetes Federation, but I would like you to see me also as someone with a lived experience, as I'm the mother of a daughter living with type 1 diabetes. So what I'm bringing here today is also the voice of the people living with lived experiences, in this case, diabetes. I would like to remind you all, because I'm sure you know, that when we say diabetes, it means to the person living with diabetes like 100 decisions to take every day. Now, if we add to that, comply with this treatment, do this, do that, count your carbs, be in range with your numbers, it's like too much to handle. And sometimes, most of the time, I would like to say, without any intention of harm or hurting anybody, we do that because language matters, because we need to help them understand that they are a part of the decision we are making about them. Yesterday, in one of the engagement, I said nothing about us without us. It can't be that we talk sometimes, we take decisions about the lives of people living with cardiovascular diseases, diabetes, any type of NCDs or other diseases, and they are not there. They can't tell us what they are feeling. So I would say, in order for any health system to be functional, to be practical, and to give us the outcomes we want, and to speak about better health, It needs to have better language. It needs to have better narrative. It needs to be inclusive. It needs to make me, as a person living with a disease, understand that I have no choice. I have to do this because I was a part of that decision. What is written on this paper was not delivered to me. I was asked to contribute. I was co-creating my treatment with my healthcare provider. I think this is what we are missing in basically every health system.
How can it be achieved?
How it can be achieved? Do you want me to go to the wording at this point?
Well,
I
I
think-
don't think we've got enough time for that. But I mean, I think it's, I completely get that it's a really strong message, and I agree with it. But it's just, how do we, we want solutions. So how do we,
Yes.
how do we action them?
Let me say, this morning, in this short while I've been sitting here, I heard the word adherence maybe 100 times, as you all did. It's a powerful word. I know indeed the intention behind it, but I have to say I don't agree with it. And I'm not saying the campaign is amazing. The outcome, the desired outcome, is what we all want. Don't we all want better health? But from my perspective, as the voice of people living with diseases, I would say it's a strong word that we might not want that, but it's stigmatizing in some cases the people with lived experiences. Why not speak about engagement? I think the outcomes would be much better, because when I say better engagement, I'm not saying adherence. I say this, you comply. I give a treatment, you go step by step with the treatment, then you have better health. Whereas when I say better engagement, let's hear what you have to say. Are you comfortable with this decision? Then we write it down. And if I go on speaking about the word control, I have to say, when I started my own organization in Lebanon, our motto was, together we control diabetes. We changed that several years ago because we listened and we understood that when we say control, it means if the numbers are not in range, then you are poorly controlling your diabetes, which means you are failing. We don't want that. We don't want this mindset, because definitely there will be no adherence. And it is one of the barriers to adherence if we go in that direction. Whereas if we speak management, you and I, as my healthcare provider, and me as a person living with a disease, then together we can manage better my numbers, my life, my health. And in that case, we can talk about better engagement, better management. Then yes, we will definitely have better health.
Sure, sure. And of course, at the end of the day, you support the improvement of better management. It's just
Of
the
course.
wording. But that is a very good way for me to introduce our next speaker, who is actually at the back of the room. I invite to come forward, Mrs. Brenda Chichindi. I'm very delighted that you're with us, and I'm sorry that you've had such a difficult journey to get here. So yeah, please do join our panel. There you go. There we are. Why don't you sit here? Be careful of your head, because I'm short enough that I don't knock it on the thing. I'll come down here. Right. Okay. So thank you for joining us. We've had a really wide-ranging discussion about the importance of adherence. We've just been talking about different ways of using that term, and maybe thinking about management for patients. Now, I think you live with multiple NCDs. I wonder if you could, from your experience, talk about how people with lived experience, how it's hard for them to maintain treatment for NCDs, and what support from the health system or from families or communities can help people take their medicine in a timely and consistent fashion.
Good morning.
My apologies for coming late. Yes. I've just read through this.
That's fine. You go ahead.
Poor adherence to medication and life changes leads to worse health outcome. Missed dosage, cessation of treatment, financial burden to purchase medication, poor communication with the health care providers, remote health care facilities, scarcity of drugs are serious barriers to medication adherence. Due to lack of knowledge, we get information from other sources, like now, social medias. You find doctors, professors with all of the medication, and they're indicating cure. So people rush just to get it, to be cured, not the supplements that we are getting. So you find a lot of people now, instead of going to the hospitals, they go to private social media with the herbal medications. And once they get deteriorated with those herbal medications, they go back to the hospital at a worse situation. I tried it myself. My brother called me, know that this medication for your BP, you'll be cured. Then I was excited. He brought it to me. And the time I took it for 2 to 3 days, I had diarrhea, vomiting. I said, no, but look. He says, no, after that it will be okay. Then I said, no. It's not safe for me. I will die. Then I stopped. But seeing those people who are getting those medications again, they had to go back to hospitals in a worse situation than they were before. Like patients, we flock to these herbal medications. And my message to healthcare professionals and policymakers, healthcare professionals, there should be fair treatment to all patients, regardless of status. Like in my country, Zambia, you find as poor people, we have a long queue to see the doctor. But with those well-to-do people, they just go direct. At times they even they distract the doctor who is trying to take care of to look after those patients who have lined up. Is disturbed, is picked to go and see that a high-profile person, of which definitely health professionals should not be dictated in such a situation. They should first look at the preference of anyone who comes first to them. And for policymakers, they should raise taxes on these risk factors, the tobacco, alcohol, these unhealthy diets, foods that are flocking into our countries, especially the third world countries now. We have a lot of processed food that is not healthy. And you find children, buying them, and mothers buying for them. And I want to urge the government to increase more taxes on those products, so that that money raised from these taxes should supplement to the healthy sector.
Thank you very much indeed, Mrs. Chitindi. And I think I should have explained, Mrs. Chitindi has been living with hypertension, I think, for 30 years, you told me yesterday. So, adhering for that length of time is a challenge. And you represent the Zambia Heart and Stroke Foundation, which you founded. So just to give you some context. I'm going to come back up here, I think, if I can climb up. Oh, showing a bit of leg. So, Hoishan has been waiting very, very patiently, and I think that the one voice we've been talking about healthcare professionals, we're talking about pharmacists, but the voice of nurses, I want you to bring that out. From your experience at the bedside and also at policy level, what are some of those effective strategies that nurses can engage to support people with their long-term treatment.
Thank you, Jackie. So, good morning, everyone. I'm Poishan Fokinade, and I represent the International Council of Nurses. I just want to say thank you.
Yeah, just bring it down a little bit. That's better.
Hello.
I think that should be better.
Yeah, that's better. Not ready. It's okay.
Yeah, okay, it's okay.
Okay, I go on. Yeah, thank you for the invitation. And for some of you who don't know International Council of Nurses, let me give you a brief introduction. So International Council of Nurses is a federation organization with more than 130 members, which are the National Nursing Association. And as my background, I'm a registered nurse. I just want to take the opportunity to say thank you for me to be part of the panel and to provide you the nursing perspective. As you know, nurses, they are the biggest healthcare professions, and we comprise of the 60% of the healthcare professionals, and we are over close to 30 millions of nurses around the world. So that's data give you an idea as why is it important to mobilize nurses to support long-term treatment engagement in patients. And from nurses' experience spanning from bedside to global policy, we play a pivotal role in supporting long-term care, long-term treatment engagement for patients with chronic conditions. And I am just going to list some of the effective strategies. So I think the first point is about building trust, as some of our keynote speakers and our panelists here mentioned. It's really important to build trust through patient-centered care. So I think nurses are really uniquely placed to develop a sustained relationship with a patient. And we do it by active listening, by showing empathy, and also respecting the individual values, their culture, and we help the patient feel they are seen and understood. So it's really a key to long-term engagement. And the second point I want to mention is about empowering self-management. So nurses, they are very important in educating patients, educating caregivers, their families, because sometimes when you think about treatment, medications, changing lifestyle, it's not only about the patient themselves, it's really about the people around them, like especially for people with elderly, or like young patient, it's really about working with the caregivers, working with their families about their condition, medication, lifestyle change. So, and we also want to make sure that those changes or recommendations are practical and culturally sensitive. So nurses are really important in achieving that. So the third point I want to mention is nurses actually are really good in coordinating care across system. So they can help you navigate in hospital setting, in community care settings, and nurses often serve as a care coordinator. We ensure that there's a continuity across setting from hospital to community, and our job is to reduce fragmentation and help patients to stay engaged by having a simplified process, access, and also communication. And not to mention, nurses have a very important role in interdisciplinary team. We work with doctors, we work with pharmacists in across different settings that patient they have their treatments and they have their recommendation from. The other point I want to mention, I think some of the speakers already touched on, is about leveraging the digital tools. So nurses are increasingly using telemedicine, telehealth, and digital platform to check in with patients. And we use digital tool to monitor progress and also to offer timely support, especially in those remote area, underserved area where regular in-person visit is not possible, it's not feasible. And last but not least, nurses, we are a big advocate for enabling policy. So I'm here now, I'm at the World Health Assembly, ICN present at the World Health Assembly. It's also shown that at the policy level, nurses are advocating for expanded scope of practice, integrated care model, and also adequate workforce management is what very important to us. We know that there is a global workforce crisis at the moment. So when we talk about how we engage with patients, we need to have enough workforce, healthcare workforce, to achieve that. So for ICN policy, we really advocate for investment in the nursing workforce, in the healthcare workforce in general, so that to make sure we can provide adequate support to patients to manage their chronic condition. So those are the points that I want to cover.
Sure. No, I like the point very much about active listening, and I wondered, is that something that is universally happening? And also in terms of the early stages when it looks as though people might not be taking their drugs in the way that they should be with these conditions. How can nurses pick up on that? Is that something that can be done to actually, snip it in the bud, as it were?
Yeah, that's a great question. I think it's a tricky question because I think nurses are really well positioned to tackle that. I mean, we're not the solution, but I think we are part of the solution. So why I said that, because nurses are often like the first one to recognize early signs of non-engagement. Nurses work there really across the continuum of care, from health promotion in the community to palliative care to tertiary care. So we are all over the places to help patients to manage their chronic condition. As I mentioned, like nurses, they're really good at like early detection through observation and communication. So we notice when patients miss an appointment, they delay their medication reviews, or patients show their frustrations or confusion about their care, so nurses can really step in to do the promotion and help them to manage their conditions.
But are they having? I mean, as I mentioned earlier on, nurses, like doctors, like pharmacists, are all really busy. How are policy changes enabling them to actually have the time to follow up on those things? Because it's quite difficult, isn't it?
Yeah, so I think in terms of that, I think collaboration is really the key. So that's why, I mean, none of the profession can really do the job. So it's really like a collaboration. It's about the interdisciplinary approach, how nurses work with doctors, how nurses work with pharmacists, like to achieve the goal, as you mentioned. And also like the question that the reply that I provided earlier, like there is a global workforce shortage at the moment. So we don't have time, we don't have the money, we don't have enough people to cater the increasing health need. So what I want to point out is really the collaboration, like in the interdisciplinary team is really important, like how we work with each other.
And I presume a single pill combination might help too with that, because if you've got fewer medications to take, then the nurses are following up fewer, in effect, and there's less medication. Medication reviews would take presumably shorter. I don't know. Is that right?
Absolutely. I think, and that's relate to the point about patient education. So if you want patient to have the high endurance adherence to the medication regime, or like behavioral change or lifestyle changes, I think that the simpler is the better.
Exactly.
Yeah. So when you mentioned about the single pill, it's absolutely like it is a solution to advance that.
Thanks for that. Okay, well, it's all been great interventions, very varied discussion. I want to open it up to the floor now for your questions. So please do put your hand up straight away, and we'll come to you with the microphone. If you could say who you are. Okay, we'll do this lady first, and then in the back of the room. Okay.
Thank you very much. Good morning. Thank you. Good morning, everybody. My name is Marit, and I'm from the International Pharmaceutical Federation. I'm the head of advocacy, communication, and marketing. And I want to contribute 2 points to this discussion. By the way, thank you for this very broad panel and including quite a variety of angles to this very important discussion. What I think maybe is missing, or maybe what should be the next destination for a discussion like this, is our heads of states or governments and policymakers. The reason I'm saying it is when you look at their annual reports, or how governments report on their success, especially the closer you get to an election, is they want to say how much medication was dispensed or was sent out to patients. Now, the volume of medication sent out to patients does not equal increased health or adherence, or whether that medication was even opened or wherever. And we as pharmacists see it a lot when patients bring back packs and packs of medication that was distributed through, for instance, a public health sector initiative. So what then filters through to the next level is to achieve that, that's how they remunerate. So if I can use the example of pharmacy, they remunerate dispensing of medicine. They do not remunerate the preventative efforts that I think you've mentioned is what we spend our time, or which all of us sitting here would like to spend our time on. And this brings me to my third point, which was made by my colleague, that, the single pill. Of course, even if we look at our diets, I'm sure all of us would have preferred a smoothie that has all the vitamins and minerals in it for today. And the same with your medication, it will be easier. But in the case of HIV, it's maybe easier. But when you come to a patient with diabetes and hyperlipidemia and maybe hypertension, we talk about personalized medicine. So you cannot manufacture maybe a single medication because the variety is different. But again, that personalized medication is so much more expensive than that mass-produced item. So I think those type of things is very important to ensure that today is not just a educational or a literacy lesson in adherence. Is to achieve it is we need to change behaviors, and we need to change them at the top so that it filters through all the way to reach the patient at the end.
Okay, thank you very much indeed for those points, and I'm delighted that Kenya obviously was here as a representative of a national government, and yes, next time we will get some more and we'll press them on that. But let me come to the lady at the back there in the middle. So, yeah, that's you. Hey. That's you.
Hi, everybody. My name's Renza Shabilia. I'm here with Breakthrough T1D, formerly JDRF, and DDoc. I am also a co-author on a language position statement about diabetes, all types of diabetes, and a co-author on the International Consensus Statement on Diabetes and Stigma. However, most importantly for the comment that I want to make here, I'm a person with 27 years of lived experience with type 1 diabetes. And I would like to say, Jackie, thank you for your recognition of the problem with language here. And I know that a lot of people will think that it's just words, who cares? But it does matter. And what I've heard today from people who clearly, genuinely want to improve the outcomes of people living with diabetes is it framed in an incredibly paternalistic way. And whilst it's been wonderful, and thank you so much for your lived experience on here, I am genuinely interested to know how many of you are truly working with people with diabetes when you are developing interventions, when you're developing programs, when you're going to policymakers. Because when we position adherence, which is such a terrible word, and I bet that you had a conversation beforehand saying, oh, we can't say compliance, we know that's not a good word, adherence will do. They mean the same thing. I would just like to say that this is a finger-pointing exercise that puts all responsibility on the individual. And what that means is that when you then go to policymakers, they've got a way out. They don't need to take accountability because it's all the responsibility of the naughty person with the health condition who is not doing what they're meant to be doing. I understand the reason for the campaign. I live with a condition that means I make 180 diabetes-related decisions every day. I am dosing insulin constantly into my body. When I mess that up, I feel it in my body. I get it. I know it. But I think that what is missing from here is it truly involving the people who can make a change and truly involving the people who this impacts. And I am urging the World Heart Federation, please change the name of World Adherence Day. It did not land well. I don't care how many hits there were on social media. It did not land well in the community. It did not. Language has been discussed across all all health conditions for a number of years now. There is no excuse to get these sorts of clangers wrong that actually stigmatise and really negatively impact people living with health conditions.
So thank you for that comment. I'm going to ask Jackie briefly to respond, but then I want to make the point that obviously we are here talking about NCDs and we are talking about many different conditions, not just diabetes, and it may be there's a different perspective for atherosclerosis, maybe, I don't know. I'd be interested to hear your perspective on this. But yeah, Jackie, you want to respond?
Yes, I would like to say, first of all, I have personally no doubt about the great intentions of the campaign, and I supported although I have the comments, as Renza mentioned, on the wording. If I can say very briefly what is my call to action, it will respond to what you are saying, Renza, because I have two parts. One, addressing the healthcare professionals, telling them that yes, language matters. If you want better outcomes, you need to speak better management instead of better control, for example, and replace the word adherence by collaborative care. And to the policymakers, although we know how much narrative and language matter, we don't have anybody who controls that, who watches that, who audits that. So please, to the governments, we need an entity that audits the language before something is public, before something is, made public. And then please promote inclusive, empowering communication standards, because then we will be having better language leading to better health.
Thanks for that, Jackie, and I think, yeah, I absolutely understand that. Michelle, did you want to come in? I'm putting you on the spot, but, can we have the speaker on, please?
Thank you.
That's
Perfect.
it, yeah.
No, I think it's a well taken comment. I think that we need to make sure in all of our efforts that we are meeting patients where they are, and working with them and collaboratively with them. I think is a theme we've talked about. We've heard many people say, how do we do it with the patient, not to the patient, right? I think that's incredibly important. And I think the International Atherosclerosis Society has a policy to make sure that patients are well represented and a part of our process, right? So we are also a federation society that is made up of medical professionals, but we have a policy to make sure every Congress we have, every panel we have, every statement we write has a patient voice, has a patient representative on it, because that is really important to be doing that together. So we just had our Congress in December in Oman, and we had an entire panel about patient involvement and social context. And so I think it's incredibly, incredibly important to make sure their voice is part of that process.
I want to come to Brenda. Brenda, when you are discussing adherence with people with lived experience, do you use the word adherence, or what other words do you use? Do you find that what people like to understand and what people use themselves?
Thank you very much. When I go into the community and discuss, sensitize the people, I encourage them to continue taking medication. I even ask them, do you complain when you are taking food, when you are eating food? They say no. It's the same kind of, the same type the same medication. It's the food for you to keep your life. As you eat your food, it's the same. So just continue taking medication. But the complaint is too much, every day swallowing. I said, yes, even every day you eat. So just continue.
Yeah. So I think we heard earlier, simple language is key here. And just a point to make that the campaign was endorsed and was collaborated with GHH and INOCA, if I'm actually INOCA. So there was actually that involvement of those two patients' associations for the development of the campaign. I do want to come on to other topics now, so bear with me, because I want to give the other people the opportunity to ask questions. So any other questions on different topics now? Jagat.
So I tell you that, listening to all, these two comments were so eloquent here. The most important thing that we really need to be looking at is the communication. Communication is the most important thing here. For example, when you talked about, say, for example, taking statins specifically when it comes for primary prevention, the person who has got hyperlipidemia is asymptomatic, specifically when we are talking of primary prevention here, right? Patient is asymptomatic. Patient comes to you, looks at the media reports. You have got muscle pain, you lose memory, your diabetes becomes brittle, this problem, that problem, you'll forget the name of this and name of that, your brain will turn into a marble and things like that. All these things that we talk about, we really need to dispel that. That is the most important. So communication becomes extremely important in all these things. I'll tell you that, and then multiple medications that we are talking of. Like now, you sure can say that there can be a polypill, and as she just said that how many polypills can you create, or how many single pills can you create, and how many of them can you really, I mean, it looks like a very attractive thing since those days of British Medical Journal when we published the first polypill article. At that point in time, we thought that we have really, this is the panacea, we have found the answer, everything is all taken care of. How much compliance have you improved by giving the polypills? Even in the secondary prevention trial. See, look at the SECURE trial. Look at any other trial. 28% becomes 36%. What did we do? Now, novel medication, once a year shot, sure. I mean, that is something which is really going to change everything. Like I get a flu shot here, and I get a cholesterol shot on the right arm. Things are going to make a difference. Again, the cost will be a problem till the cost comes down. And mRNA therapeutics, the cost must come crashing down. It is not like biologics where you are using antibiotics and all. These are chemicals. The cost has to come down. So I think it is extremely important that we come up with such kind of things which take the burden away from the patient. Now I'll tell you how communication makes a difference, and I talked about it in World Heart Summit also 2 days ago, that in Harlem, there is a person who has 4 practices. He serves only the Medicaid people. And so basically, they do not want to go and buy 4 or 5 pills for 1 month where they have to give $50 copay. $10 each of those medicines, and stand in the line and get them. So what he does is he orders millions and millions of pills. His wife sits down, creates a pill box, right? And puts it for, like, this is in the morning, this is afternoon, and this is in the night. There was one patient who came right in front of me, brings back the pill box and says, "Doctor, I could not take it on 14th evening and 15th morning because I drove from New York to Philadelphia to see my daughter. But it snowed there and I could not come back, so these 2 pills are left." Right? That is compliance, or that is adherence, or whatever we want to name it as. And what's in a name, I do not know, but still, sure, it might make a difference. But communication is at the end most important thing. That is what I believe. Without that, we will not reach anywhere.
Yeah, so we've got 1 minute. We've got 1 minute left. So Jackie wants to answer that to Jagat, and then I'm going to ask for a final point, I think, from Kumavi, because you haven't said anything in this panel discussion. So what's your final takeaway in terms of a concrete solution moving forward for the campaign? So Jackie, your response to Jagat.
Thank you very much.
Oh, hold on. I'm going to come to Jackie first, then you. All right, 1 second.
Okay,
then we'll
so
close.
Communication is excellent, what you are recommending, Doctor, but two-way communication, not just any communication. And I want to say that we at the International Diabetes Federation are minding so carefully the narrative and the language to a point where, I don't know if you have noticed, I have never, even single once, used the word patient. I say the people with lived experiences, people living with diabetes, and being a mother of a daughter living with type 1 diabetes, I know how much that makes a difference. We may think they're just words, as Renza said, but they are not words. They can be hurtful, although it's not your intention or my intention. They can do that. And so let's stress on two-way communication, and remember something. Science is excellent. We love it. It saves lives, but what is it about? It's about people. So let's mind the narrative in order to show how much we care for people and what we definitely mean by person-centered. Yeah. We need to listen to that person and not say any stigmatizing or hurtful words. Thank you.
Oh, no,
okay.
I absolutely love what you say, that it has to be a two-way communication. Yeah. The patient comes to me, I mean, like this happens with me every single day when I'm treating my patients, right? That the patient would come and tell me, "Oh, I've got a borderline change. It's the blood pressure is borderline." You really need to communicate with them that there is way more problem when you have got a borderline increase of 2 risk factors rather than talking of the extreme risk factor. Then the other one would say that, okay, you know what, I can take care of it by exercise and by diet. Don't worry about it. And then you have to sit down with them and explain those things. So I absolutely agree that it is a two-way communication. Sure, the language would make a difference. Now, we used to call inequities, they don't want us to call it inequity, they want to call it for health for all. Sure, I think it's much better, health for all.
Okay.
It's a much better term, so connotations would change. I really agree with you, specifically as you said, that can be changed the adherence. Let's have an award competition, set out $5,000, Servier will do it. And,
Well,
and say
fighting talk there,
can we-
Jagger.
What can we bring? An open competition.
Right.
Let's get the new names for it.
No.
Are you, Viviana? Are you?
Now I've got to close this event now, but I do want Kamavi to come in. I want to have a final put like a concrete solution, and also just in a final word to put to him. How about the WHO endorsing World Adherence Day?
Thank you so much for the question and the very, good discussion so far. Someone says at the beginning that adherence or compliance or good treatment is personal, so the solution should be personal as well. But I just wanted to add on that, yes, it's personal, but there are multifaceted challenges surrounding it, from policy level to healthcare worker and to the patient itself. So I don't think usually I remember when we were discussing before this meeting, I had that, since they say, okay, 3 things: education, digital solution, single pill. Yes, nice, but I don't think that's the solution. The solution is different. It depends on the patient. It depends where the patients live. It depends the environment. It depends the country. It depends the language. It depends the level of education of the patient. So this is a more complicated and complex issue. And I think we don't have the correct solution depending on, the personal state of the person we have as a patient. Sure. So having said that, what I would say is we need to continue discussion. We need to continue communicating. We need to continue doing the advocacy to make sure that, we have that information in our different languages. Yes, maybe adherence is not a good word, but if you come to my mother tongue, how do you say it, So those are some of the questions we need to keep in mind. From WHO's perspective, talking about this day, I think it's not something that we have discussed, that we are now invited to this meeting. We can still have that discussion at, at the organization level and see if it's something that you in general can consider. But as I have heard, the wording already is challenging, so we need to, have further discussion and see what's doable. Thank you so much. Yeah.
Okay. Well, this discussion obviously could go on for another hour, but I really do have to bring it to a close. I'm really grateful to our fantastic panellists for all their great contributions. Thank you to your audience for your comments. Thank you to Servier and World Health Federation for hosting.